It is my honor to introduce our first speaker of the morning, Dr. Don Jenkins, not because of his professional experience, which is outstanding, but because he is a very good friend of mine. He is currently in San Antonio, Texas. But before he moved to San Antonio, he was my parishioner in Holianagiri in the northern frozen hinterlands of Minnesota, and was on my parish council, and also is continuing, even though he is 1,000 miles away in a much warmer climate, he continues to be the executive director of our Philoxenia House Ministry at Rochester, which we offer housing free of charge to those patients who are coming to Mayo Clinic for treatment. And he's still very much the head of that. And on behalf of our parish, I want to just say a very quick thank you before I introduce Dr. Don Jenkins. He, and I already reprimanded him this morning, as I'm known to do, his bio is not accurate. What you read here is a tenth of what this man has accomplished. One of his very good traits is that of humility, and I'll point out one of those as I introduce him to all of you. Dr. Jenkins is a clinical professor in the Division of Trauma and Emergency Surgery at the University of Texas Health Science Center in San Antonio. He formerly was a consultant in the Division of Trauma, Critical Care, and General Surgery, and a professor of surgery in the College of Medicine at Mayo Clinic. That is inaccurate. He was the head cheese. He was the director of the whole trauma department at Mayo Clinic. Dr. Jenkins previously served as the trauma director for numerous military trauma centers, including ones in Iraq and Afghanistan, and retired after nearly 25 years of active duty service from the United States Air Force in the year 2008. And he has received many national awards for his work in battlefield medicine, which is an incredibly focused area of medicine. You can imagine the stress and the anxiety and the pain and suffering that our men and women in uniform experience on the battlefield. So without further ado, please welcome Dr. Don Jenkins, our good friend.
Well, thank you. If I speak this way, can you hear me okay? Everyone in the back? We're good? Excellent. We're good. We're good. Very good. Well, thank you for that generous introduction, Father. It's a delight to be here today. Thank you so much for the invitation to come and speak on the medical perspective related to pain and suffering. I'm not sure what your expectations are of the talk today, but I'm going to spend a fair amount of time doing things that Father Sean has done for certain in the combat zone. We're going to talk about trauma and injury in this country. It's an epidemic. People are unaware of it. Trauma centers, large and small, across this country on a daily basis are caring for life-threatening injuries in patients, and the special pain and suffering of those individuals I'm going to try to describe as best as I can, and leave it up to you to help me figure out what we can do about that. It's a problem. So I'm going to start out with a very brief military vignette and switch over to some of the civilian issues and move back again. So this is the location that I was deployed to shortly after 9/11. Pretty rough and tumble kind of a place. Accidents waiting to happen everywhere. And the very first injured casualty was a Special Forces troop who, unfortunately, in the middle of the deep, dark night, was pinned between that truck and that water container and had an open pelvis fracture, bleeding open pelvis fracture, highly fatal injury. Now, to treat that, this is the team of folks and the equipment that they had available to them. So a little less than maybe you've seen on Chicago ER. Is that better? Excellent. And sadly, I'll tell you that there is no chaplain present for this team of folks at this location at this time. So following a medical evaluation of this patient where we looked them over head to toe and realizing that this is a very remote and austere location where there's no x-ray, there's no laboratory, you can do one of two things: operate or transfer. And transfer is not necessarily an option. So they took the patient to their operating room, the complete formulary hanging on the wall for the hospital. That little tiny machine with the hose is the entirety of the anesthesia machine. And a little folding chair like you're sitting in for the anesthesiologist so they could do their crossword puzzles. Any anesthesiologists here? Sorry for that. Couldn't resist. So our task was control hemorrhage, control the contamination, the dirtiness of the wounds, and get that casualty out of that location. A team was able to do that, and we'll see that at the end of this discussion. But evacuate that casualty to the next level of care available, another bigger tent hospital with more folding chairs and small anesthesia machines in the middle of the desert. Well, let's bring this back home for a bit. Nearly 200,000 people die in this country of injury every year. And it kills more people under the age of 45 than the next 5 causes of death in that age group combined. Kills more children than all the other causes of death of children combined. 9 million falls, 3 million car crashes, 30,000 gunshot deaths, most of which are unfortunately suicides. And it's a terrible problem. Where I come from, it's not much different. 85,000 people a year injured or killed in some way, half of that practically intentional. There's a map from 1988 before the development of trauma systems in the state of Texas. Those counties colored in red are counties where the death rate from injury is more than 50 per 100,000, which is the CDC definition for epidemic. This was called the blood map before the state of Texas adopted a trauma system 1 year later, using this data to convince the legislature to spend money to make this happen. Fortunately, this is much more gray today than red because of changes that were made. When we're dealing with injured patients, this is, as Father hinted at, the urgency with which one must act. About half of those who die at the scene. They don't ever get into the back of an ambulance. They don't get to a hospital to be taken care of. They have fatal injuries from the beginning. About a third of those who die within immediacy, within an hour or so. And this is why we have 911. This is why we have professional and volunteer EMS services. This is why we have trauma centers, is to save the lives of these patients. If we can't save the lives of these patients, we shouldn't be doing what we're doing. We need to go back to the drawing board and figure that out again. And then the remaining deaths occur as patients linger in an intensive care unit with bad brain injury or multiple organ failure that follows. About 1 in 400 injured die. If you have to be hospitalized, your chances of dying go up to about 2%. If you need a transfusion, now we're talking about a 1 in 5. And if you need more than 10 units of blood, that's nearly a 50-50 proposition in terms of whether or not you live or die. So brain injury is number one killer of injured patients. Hemorrhage is number one cause of preventable death in that patient group. And as you can see from this autopsy study, it doesn't take terribly long to bleed to death. 22 minutes from a gunshot, 28 minutes from a blunt force injury. And so that means all those things we talked about, looking a patient over head to toe, taking those x-rays, getting those laboratory studies, and stabilizing that patient, you have precious little time to accomplish that task. So the physical needs of the patient must be met to save their life. This is time critical, and the team sacrifices for the patient. There's a certain emotional distance that occurs naturally in these situations, which can be good and bad. And that environment is very sterile, objective. There are values that we get a blood pressure, we write down a blood pressure, we get a hemoglobin value, we give a transfusion. We're very precise about how we do those things. However, the emotional and spiritual needs of the patient are not at all addressed. Not something I was taught in medical school to look after these patients. And I'd ask you how you do that. Because if the goal is to get that patient out of that setting within 15 minutes, there's got to be a lot of things that happen very rapidly and make a diagnosis of where the hemorrhage is coming from, because you have, again, precious little time to do something about it if you're going to save that patient's life. So this is the sum total of the things that need to be done in that 15-minute period of time by a team of people. And it takes a lot of teamwork and team training to get this right, and to get this right every time. There's really not much margin of error if you expect to save the lives of patients whose life is in peril. So I teach a lot. I teach a lot of team training, and part of that is about being a leader. So leading a team of individuals. So they're the basics, like we just showed, right? We can graphically represent them. These are the tasks that need to be done. This is the time frame in which they need to be done. We've assigned certain team members to each of those tasks so that there's no guesswork in who's going to do what and when. And teamwork in this setting is quite a bit different, because it's not you and your team that loses, it's the patient who loses if you can't do things the way that they need to be done. So just like any take the Cubs, right? So they had, yeah, okay, that's it. You can clap. It's okay. So they had a clear mission, right, to wipe out the Greek goat curse of 108 years that have kept them away from the championship. They had a plan. They knew who was going to bat in what order. They had, knew who was going to pitch in what sequence. Very organized roles. The catcher doesn't go out, to the outfield. It's just not. That's not how things go. They have their job. They do their thing, and they own their position. That area around first base, that's the first baseman's area, and then there's nobody else that can get that ball when it goes, screeching up the foul line. The capacity and ability, well, it's different for the Cubs than it would be in my more or less all-volunteer organization, where we're more like the grade school kickball team. And you have to understand the capacity and the capability of the individuals you're working with when maybe you've never met them. The place that I worked in Rochester, the place that I work in San Antonio, there are so many nurses, so many physicians, so many medical technicians that we could do 1,000 trauma evaluations and never have the same team assembled at the bedside. Now, lead that team, right? Again, going back to grade school kickball. And so there's a certain amount of trust that has to be there, but there has to be a certain amount of leadership that can identify when things aren't going right and when someone does not have the capacity. Sometimes, when that emotional distance fails, and it fails more often when we're resuscitating a child, I'll just be blunt about it. I took care of a baby, 1-year-old, 27 stab wounds in Rochester, Minnesota, whose intestines were literally out of the abdomen. I got called emergently by my partner, who had 2 stabbing victims at the same time, because he needed help. And I went to that room, and the room was frozen. There was no activity. No one could take a step forward. It was just so ghastly to them. And that's where the leadership bit kicks in. That child did great. Had a couple of different life-saving surgeries, but has done fantastically well. And so it's in that situation that, as the leader, not only have to control yourself, but control the environment. And here's this: control the patient as if they are an inanimate object. And that is the case. You also need to control the crowd because crowd noise can be quite problematic. Unlike the first picture that I showed you of a small team addressing the needs of an individual, I would challenge you to find the patient. Anybody see a patient there somewhere? With all those team members that have assembled around the patient. And this is that crowd that gathers at the patient's bedside. And when it's really bad, like there's a telephone pole sticking through some guy, that's when people are, you got to come down here and see this. The dietitians show up because no one's ever seen anything, this terrible. These are real events that happen, and you have to be able to control that group of folks. But with all those people in attendance, again, I would take you back. If you looked at that photo, there wasn't anyone whispering in the ear of that patient that things were going to be okay, or did they have questions or concerns that needed to be addressed? And the pain goes without saying. Patients often ask me if they're going to die, or they ask me to not let them die. And that's a question I don't really have a hard time answering for them because I've been very well trained and I have a lot of experience. And I can look that patient in the eye and tell them they're not going to die. Now that may or may not be true, but that's what that patient wants to hear at that moment in time. And it's the one small thing that if I can reach out and give someone a little something for their psyche, it might be that. These patients have a surreal experience as they. I think this thing is falling down. There we go. Sorry for that. These patients have a surreal experience being poked and prodded. Many of these patients are given medications that then cause their mental capacity to be impaired because they have pain. We want to give them pain relief. Then they have difficulty interacting with their environment and those people in and around them. They have a hard time understanding what's happening to them. Sometimes the patient's intoxicated on top of all that, which doesn't lend itself, where they have a concussion, as the case might be, that further impairs their ability to interact with their surroundings. So in my world, physiology trumps everything else for these patients. That life-saving interventions take priority to restore that physiology, and there's really not much time to inform the patient of all the things that are happening. Life-saving interventions pretty much cause more pain in every regard. And as I said previously, precious few opportunities offer themselves to address the psychological, spiritual needs of the patient in this phase of care. Then what happens is that reality sets in. The patient makes it through this resuscitation. Maybe they get an operation or two. Now they're hospitalized, and things start to come around. And they realize that their entire life is turned upside down. In Minnesota, a farmer injured with a broken leg and pelvis at harvest, that's a life changer. That's a crop that's not coming in unless their friends, and they do, get out there and help them with that. The loss of employment and income, their loss of autonomy. We were just talking about, I'm wearing a pin up here. Might look from the back like it's a political pin. It is not. Elizabeth Dole Foundation created a movement. It's called Hidden Heroes, and it's for military health care givers. Her husband, Senator Robert Dole, had been hospitalized at Walter Reed, and while visiting with spouses of injured service members in the waiting room, waiting to go see her husband, it occurred to her that these folks experienced all of this. They were there visiting their injured service member, loved one, family member from 80 different places from around the country. No support network where they were, although they feel good where they are because there are other people they can commiserate with. when that dreaded day comes and they get dismissed and have to go home is a very fearful day for them, because now they're going to have to do medical things that they were never trained to do on their loved one that may cause pain, and without any formal training or formal network. And so she just kicked off a big campaign to recognize those folks and make that easier on them. So it's not just about the patient at this point in time, it's about the family as well, having to deal with these issues. Now, the caregivers themselves are dedicated and highly trained and motivated professionals and do this day in and day out, and they're very proud of the great work that I do. But burnout for them is a real issue. Most trauma nurses, ER and ICU nurses can't hold that job for more than about 5 years, and they start to look for jobs in a clinic or an outpatient setting with more and regular hours because of the daily wear and tear on them. Our social workers are so busy taking care of the practical needs of most of our patients that the things that they were, I think, really trained to do and probably went into this line of work in the beginning to fulfill their professional goals is not able to be done. They can't counsel patients because there's just so little time in a day as they play discharge planners. And then there are the concepts about a debriefing. So in that case of the injured child that I mentioned earlier, an attempt was made to hold a debriefing the next day, and it was a disaster. It was, people just could not wrap their minds around it yet. And I think if you're going to do something like that, it needs to be done in immediacy and not several days later, and it just was not well orchestrated event, and I think maybe made it worse for some people. I don't know why it keeps tipping. That's what we needed. Thank you. So we have this now from a civilian perspective, I think, nailed down in terms of what takes place. Let me just add a layer of difficulty into that and take us into the deployed environment. And again, people with military experience in the room? Several, okay. So you'll call me out if I say something wrong, right? So military health care in trauma and injury just adds a layer of difficulty. It's kind of like an Olympic sport. You get that fudge factor, because the dive you're about to do is so much more. Because we're expected to do that in these echelons of care, start out with small teams, move the patient along the way. Rather famous in trauma circles, trauma surgeon from San Francisco said about her experience in flying injured casualties from Germany back to the United States as a volunteer on a couple of occasions, that we put people in the back of an airplane to fly them across the ocean that she wouldn't dare put in the elevator in her hospital. And again, it's a different kind of a thing. So when I got out of my training, this is a brand new concept that had come forward, this small surgical team. And this was to get surgical capability closer to the time of injury. Because in the first Gulf War, about 75% of the patients that ended up needing surgery got that surgery more than 6 hours after their injury. As we laid out for you, the physiology does not favor that. There's a lot of dead people that didn't get surgical care when they could have or should have if we thought differently about how to do this. And so the Air Force put me in charge of that team, put me in charge of this one-tent hospital. It's got 2 ER beds and 1 OR bed, 1 ICU bed, all crammed in a little hospital. That's us in Naknek, Alaska, testing out the cold weather capabilities and to be sure that the heater worked before we fully deployed this across the Air Force. It all fits in that little hot dog stand truck there. And you can take it just about anywhere and be able to care for a small amount of injured patients. So it's a 10-person team. Got that 3 beds like I talked about, and a population at risk of about 500 to serve on an airbase setting. You can add capability to that, and this should be plug and play, sort of like adding things on to the computer here. It should all function properly. And it doesn't matter where those personnel or equipment comes from, it should all be identical and plug in. And so this is how the Air Force built up this system. And you can just add more 25-bed segments as you saw fit. Well, I happen to be carrying a pager on 9/11 that was part of the deployment team for our go-to-war hospital. And we activated a 25-bed hospital, loaded it up in a big airplane, and flew to New York City. Went to McGuire Air Force Base in New Jersey. And unfortunately, there was nobody to care for. There had been 25 beds set up by the folks from Langley, Virginia, and we held the rest of the beds in reserve. But we coordinated with civilian authorities, and their number one need were nurses for a burn center and psychologists for mortuary affairs. And we were able to supply some personnel with that. But we also did some training. And because we figured that President Bush was not going to stand idly by and was going to want the military to go into action. We weren't sure where. We were pretty sure we'd leave right from there, though. We didn't. We went back home to San Antonio. And little did I know that over in U.S. Central Command, this is the plan that was being hatched with this, what they call the Red Wedge. And you can see the 5-person mobile field surgical team is right up at the front of that group. This was the double secret location to which we were deployed. In fact, my orders say Operation Infinite Justice, not Operation Enduring Freedom, which got changed to a little bit later. That's another story. I affectionately refer to this desert island off the coast of Oman as a pimple on the butt of Oman. Miserable place, hadn't rained in 18 months. There's no sand there. It's like confectioner's sugar dirt. 130 degrees at 4 in the morning when we get off the plane. I was the 39th person on that island to set up. This was our team. So we had a 5-person team that we took forward. We took our trailer that you can see there with our stuff in it. Had to leave the rest of the people behind. To come later, we were equally deployed on that plane with cooks, firefighters, and security forces. So a nice combination of people that you need to stand up an air base. We occupied an air base. It was kind of like an old West ghost town that had been abandoned a decade earlier. Literally 20 feet high piles of this sand in the corners of the warehouse. Had to get all that stuff cleared out. This is that environment where we were. Quite a dangerous place, if you will, just from an military-industrial complex. Activity going on 24/7. As we waited for water to show up, and we weren't sure how long our water supply would last or when the next plane was going to arrive. We waited for tents, we waited for food, and it was, like I say, a pretty miserable existence. So this was the plan that was given to us. We left San Antonio the 20th of September of 2001 to go and fulfill this mission. We took our 5-person mobile surgical team, our 3-person critical care team. When we got to Oman, we had initial operating capability within 15 minutes of arrival. We had our first trauma case, which was a security forces guy on one of those 4-wheelers who flipped it, and we weren't sure if he had a spleen injury or not. Fortunately for him, he did not. And we were ready to go by the 13th of October of 2001 with our whole team of folks. Now, mind you, we're not here to take care of injured combatants. We're here to just do medicine on an airbase where people get hurt. The very first insertion of troops into Afghanistan was by airdrop, so paratroopers. And the loadmaster on the Special Forces aircraft about to drop those guys, as they were loading those guys on, fell off the tail section of the aircraft and had an open fracture. So he was our first real operative casualty from combat at that location. This is where we started with our little corner in the tent, in the corner of the warehouse, and set up a little bit of a clinic, and I think that's our patient who was injured and had a concussion. This is us building our own hospital. There's no one to do that for you, so you get to be skilled at any number of additional activities in addition to just knowing medicine. So that's the hospital as we built it. This is the base as we built it from nothing, and that's what 10,000 people in tents looks like from the sky. You get to know your compatriots quite well. Stayed in that little tent with 11 of my closest friends for about 6 months. But we were ready to go to do what we needed to do, and we waited. We got to know the other people on the base and the things that they do, so that we'd have a better rapport with our patient population, understanding their mission. So this was the largest initial base build-up in the Southwest Asia area of responsibility. And then we got the news that they wanted us to be the casualty receiving center for all of the invasion phase. And it's like, how many? How many casualties? 30 simultaneously. Okay, I'm going to need a little bit more stuff and probably a few more people to meet that mission. So we went from a 1 OR to 4 OR hospital, 3 ICU beds up to 10 ICU beds, and a 30-bed staging facility so that we could get those folks ready to get on an aircraft and be evacuated off this desert island. We had to send one of our logistics officers with a pretty limitless credit card, apparently. Had to take a truck, get on a ferry to go across to the mainland, drive to the capital city, and he brought us back about $1 million worth of equipment. We had it outlined, everything we needed, all the ventilators, all the surgical tools, suction machines, you name it. We had it all lined out there in terms of supplies and such. It just is all on a different electrical circuitry, because it's not US 110, it's overseas 220. So we had to have a separate generator and put in separate line. And mind you, we've got about 36 hours to the invasion as we make this transition to be ready to do that. And then these guys do what these guys do. God bless them. They went in and secured an air base in the southern part of Afghanistan after about 3 different airdrops. And this is my partner and I operating on those injured combatants as they were flown back to Masira Island. There were only 54 in that first week, and then once they were able to establish a foothold in Afghanistan, we never saw another injured combatant. A single chaplain for that airbase of 10,000. And no disrespect whatsoever, he was not ready for this. He and I did a lot of one-on-one counseling. It was either over coffee in the dining facility or, oddly, in the shower. Big community showers, and we just happened to be there at the same time a lot. And I think we both got a lot out of that relationship. We were able to convince him to come to the hospital and visit the sick inpatients. That was not high up on his priority list. Do we have chaplains here with us? Outstanding. We also did some other fairly novel things. This is what I call the ultimate in cross-training, because with one orthopedic surgeon, one visceral surgeon, and one nurse anesthetist, if one of us, if the orthopedist gets a broken bone, I'm going to have to do something about that. If the nurse anesthetist gets sick, someone's going to have to provide her anesthesia. And so this is me operating with the nurse anesthetist, taking out an appendix, while the orthopedist is providing anesthesia. And so it went. We did this cross-leveling, this cross-training. We used dental technicians. They're experts in radiology. So we trained them how to take x-rays of the chest and abdomen, pelvis, extremities. They were very helpful in instrument sterilization in the operating room. because that's another thing that they do. And so it went. We trained high-end paramedics to assist with the anesthesia, what we called maintenance of anesthesia, so we could operate on 3 casualties simultaneously, and made the best out of the circumstance that we could. Wouldn't be a complete picture if we didn't talk about the medics. And this is a fairly typical scene in the back of an Army helicopter after there's been a firefight. And if it looks a little bit chaotic, it's because it is. And do that at 140 decibels. You try to listen to someone's lung sounds or take their blood pressure or. And traditional medicine goes out the window. And so we did a lot of training with our medics, not only U.S. medics, but UK medics, German medics, before they went on to Afghanistan. Remember that picture I showed you of a busy U.S. trauma center? This is a picture of a similar scenario, but there's about 10 casualties here, all from a single bombing accident where a person called in an airstrike on themselves. They were using their GPS to identify the coordinates where they wanted the bomb to drop. Their device went dead. They changed the batteries and then read the reading off of the device, which unfortunately they didn't know was reset when you take the batteries out to your own location. And so they gave the grid location, and there's a friendly fire incident. This is that group of folks that made all that happen. What I can tell you is that in terms of combat casualty care, over time in Afghanistan and in Iraq, the injury severity has continued to increase. The number of multiple amputees has continued to increase. Mortality has stayed the same or actually gone down because we've learned lessons and we've applied those lessons in a rather rigorous manner. So any mistakes we made early on, we didn't make again. And it's teams of folks like this. You know what I didn't mention was the 60-day communication blackout. So when we left San Antonio, there was no communication with anybody outside of the team, period, the end. Not that there was any capability for it on this desert island to begin with. But there's a group of us who went out on 9/11 and then on this deployment that follows, this whole thing with let's roll, never heard of it. That didn't happen, like Rumpelstiltskin. There were about 75 days that I have no idea what happened in the outside world, along with the rest of this team. Now, military folks have a tendency to be leaders and in charge of things and their families. We had one fella terribly distressed. His 40-year-old wife was having their very first child. He left her at bed rest with preeclampsia. No way to contact her. Another fella whose Korean-speaking only wife had a 5-year-old, no driver's license, and thyroid cancer, and was supposed to be getting radiation treatments. No idea if she was able to get those or how that was, what exactly was transpiring. So you want to take people out of their environment, put them into this 130-degree, let's build some tents and we don't know if we have enough water, and do a job you weren't expected to do, be outside of their network, and not be able to care for their family. That's a pretty tough circumstance to be in, all things considered. And so pain and suffering of the caregiver is probably a part of this as well, that we should pay attention to. So over time, this is what happened, and units were deployed to the invasion in Iraq. We did a lot of work to try to build a trauma system out of these individual moving parts, which is where we got the opportunity to work for United States Central Command and build a trauma system there. It was appalling to me that there were so few opportunities for Orthodox service members to have services. Every base I visited, and I visited 50, every place there's an operating room table, been to them all. Wicca services, LDS services, any day of the week, all week long, In 700 days deployed, I only ever met 2 Orthodox chaplains. It's Father Jerome. As you can see, it's not your usual vestments that Father Jerome is wearing. Literally 5 minutes before I took this photo, a rocket landed about 100 yards from this makeshift chapel tent. But every time Father Jerome was in town, we drove all the way across base and had a little liturgy where you could see more people native to Iraq as parishioners there than U.S. Service members. And yeah, that's me, that skinny guy in the gray T-shirt. It was a different era. So what happened on the very first casualty we talked about? Well, he got his second operation in Turkey and was evacuated to the continental United States. I met him about a year later when I was visiting Camp Lejeune, where he was undergoing his final reconstructive surgery. And it's a real testament, I think, to the differences in medical care provided. Now, that fellow's got lifelong pain to have to deal with as a result of his injuries. And I don't think that was made better by being in the environment he was in, or the fact that we poked and prodded him like an inanimate object for the first 15 minutes to be able to save his life. So I think we have to find a better way to integrate care of the injured to address all of their needs, not just their physical needs. And that there needs to be collaboration of healthcare and spiritual care specialists to provide the best care, not only for those injured, but the caregivers themselves. Because the resiliency of those caregivers suffers and burnout happens because, I think, of the lack of attention to the psychological and spiritual needs of that team. Chaplains need to be indoctrinated into the vital role that they can play in trauma centers, not only for the patients, but for the caregivers. So with that, I would like to say thank you very much for your time and attention and allowing me to address you here today.
Thank you very much, Dr. Jenkins, for your compelling and eye-opening presentation. We can take some questions. We'll go back for the mic.
Hi, thank you. My name is Chris Durante. I'm a professor of ethics and religion, and I work in bioethics. I have 2 related questions. Well, one is, in what manner do you think ethics comes in terms of what is the most relevant ethical issue you face in wartime? Would it be one of resource allocation in terms of justice? What is just allocation of your resources in that situation? And how do you deliberate about such difficult decisions? You said you had to start making more ORs, right? More people coming in, but you're tight on resources. So if you could speak to that, and in what way do you think chaplaincy or spiritual care could more directly, pragmatically be improved in terms of maybe the training of chaplains who are trained to go in, or better training to go into these wartime situations? I also work on the ethics of war, so I'm curious to hear your perspectives of these things.
So in terms of ethics in the combat zone, one thing to make clear up front is that the most injured patient is not always the one that gets the most attention, because if you have 30 simultaneous casualties that arrive, you're going to have to make some hard decisions. On average in Vietnam, it took surgeons 6 weeks of experience to get to their optimal triage level, meaning that they had the most survivors, because they would often early operate on the sickest patient who had no hope of living, and not only did that patient die, but a subsequent patient that may have been saved did not get life-saving surgery and also died. And so there's a lot of background training and work that we do specifically with triage. The other thing to know, be very clear about, is that it doesn't matter what uniform or civilian attire that individual is wearing. They get the attention that they need when they need it. And you want to talk, plenty of times I've been in the trauma bay taking care of a drunk driver who injured this family, and they're all there together and taking care of them all simultaneously. We'll now do that with injured Marine and the insurgent that shot him and then got shot by the Marines at the same time. Who takes priority? It doesn't matter what flag they wear, the patient needs the care, gets it. It was this experience from 2001 that caused me to go back to San Antonio and work at the Air Force Hospital with our chaplains program to help get Air Force chaplains ready to do a go-to-war job. And at every opportunity would tell them, go to the hospital. There would be celebrities who would come through these bases and visit with people, and I would do my best to track them down and tell them, if you don't go to the hospital, you're making a big mistake. You got to go meet with those people. They need the morale more than the people who can stand up on their own here and applaud for you. You need to go and help them. And so we try to put in place a training program for chaplains through that to make that more effective.
My name is Melinda Johnson, and I'm very touched by the stories that you have shared with us. I, in fact, was a lieutenant stationed in Muscat from 2000 to 2001. And I have been to Masira. We said
it's an armpit.
We always said it's not the end of the world, but you can see it from here. Because, in fact, if you looked south, if you went straight south from Masira, there's nothing until the South Pole. And I was part of the team at the embassy that put together these war reserve materiel units and had them in storage for exactly this calamity. And so I appreciate your stories. This kind of brings full circle the work that we did in preparation, and it's also a driving force of why I went into social work. And so I also appreciate your comments about chaplaincy and how critical it is for the troops that are stationed very far away from home. When things are still happening at home, your father might still have a heart attack, for example, when you're stationed 10,000 miles away. And the work that a chaplain could do in that situation is very important. I also just wanted to briefly mention that my father was also I'm sorry, I'm a little bit choked up from your stories. My father was also a physician in Vietnam, in Cu Chi, and in 1967, and so it was wonderful to hear the progress that has been made in triage. And one of his favorite photographs from that era was of Easter Sunday with bombs going off in the background. So some things have changed and some things have stayed the same.
Some things haven't.
But thank you for your service.
You're welcome. So I'll tell you a little vignette to go along with the catching back up with the folks at home when you can't. So after that 60-day period of time, it was actually 59 days, I'm exaggerating, not that anybody was counting, the communication blackout was lifted. And we all were given an assignment for a 5-minute phone call and to show up at this communication tent that they had set up with about 30 phones. And there was a group of chairs almost exactly like this set up on one of those dusty roads outside of that tent. And every time somebody walked out of the tent, everyone stood up and moved over one chair and sat back down until their turn came. And then what you didn't know was there was more waiting on the inside. But people, as they would come back from this phone call home, had all sorts of stories to tell, most of them out of frustration. My wife bought a refrigerator. We did not need that. My wife bought a car. So when my call went home, my wife answered. I don't know why or how. And I said, I'm fine. Everything's fine. We're safe. How are the children? I bought a house. That's good. So how are the children? But eventually we get back around to it. So tell me this thing about you bought a house again? Because no one can beat that story, right? It's absolutely true.
I appreciate your words of encouragement and bringing to the forefront the great role of the chaplain. I work in a level 1 inner city trauma, so I'm curious of what exactly have you done or would you recommend doing for the training of hospital chaplains to be the part of the trauma team? With the experience that in our hospitals, we try to be a support to the staff by offering, we call it the pause. After each code, the chaplain calls for something like 1 minute where everybody pauses as acknowledging the work that they've done, whether it's a prayer or not. But also the chaplain sometimes is dumped on the work of crowd control. So if somebody comes in with a gunshot wound and then there's 40 people waiting, the chaplain is the one kind of like bring 2 at a time and go and be there. And it's somehow disturbing that it takes away from the spiritual support that we could offer, including to the staff. So maybe you can speak a little bit of how do you see the role of the chaplain in the trauma other than simple things like crowd control?
Sure. So what we did in San Antonio and what we did subsequently in Rochester was we put the chaplain on call on a pager, and they got every trauma page that we got. And they would show up for those codes. Interesting to put you in charge of crowd control. Hadn't thought of that. That's a really good idea. Oh no, I'm sorry. Bad idea. Yeah. So part of what we did in terms of indoctrinating the chaplains is that this isn't for everybody. I mean, I don't think I spared you all of the gore. We talked about some of it. But until you get up close and personal to it, you don't know how you're going to react to it. And I think that there's something to be said for pairing up an experienced chaplain with an inexperienced chaplain the first few times that they take that call. I think that getting to know the team members who are going to be present for those evaluations and resuscitations before one happens is important. To just take a stroll through when it's not busy and look the team members in the eye and let them know you're there for them. I think that goes a long way, and then that you are a resource. You're not wearing an X-ray lead apron. You don't have the scrubs and the IV needles and stuff like that. Hopefully there's some way to denote that you are the resource for the spiritual and psychological needs of the team and the patient. It was the sort of written agreement, I guess, that we had was that the chaplain would hang back and not approach the patient until given permission by the person in charge, so as not to interfere with the physiologic and physical aspects of things. And they were very good about, after not much experience, knowing when it was time to do that. And their presence was obvious, and the team uplifted by that would be my experience.
My name is Eric Ruthford, and my son was born at 22 weeks and 6 days of gestation. And my question for you is about when it comes time to decide on whether to resuscitate a patient or to provide treatment to a patient, and it's a time when you can decide to do it or not to do it. From a Christian perspective, how do you process that, and how do you make that decision?
So in terms of knowing when and when not to resuscitate a patient, it's a pretty fine line and difficult for most who've never made a call to stop a resuscitation or to not resuscitate a patient. And in my world, there's some pretty cut and dried rules. If you're injured by blunt force mechanism, some kind of a vehicular crash, some kind of a fall from a height, and you are pulseless, you are dead. And it doesn't matter how long EMS worked on you before getting you to the hospital. There are certain things that we know. If you're bleeding to death from your liver and from another site, that's fatal injury. If you have 5 millimeters of shift from a subdural hematoma and no neuro signs of life, you're dead. In 2016, we can't resuscitate those patients. And so we look to the science part of it to help us make those decisions. Now it gets tougher in that combat zone where I've made the call to say, well, I think we might be able to save this guy, but I can't save those 6 people trying to save this guy. I think he's just a little bit too far gone. What we call putting someone in an expectant category and give them comfort measures only. Probably the single hardest decision to make, and one that has to be taken into account based upon resources, other incoming casualties, because that's another mistake that you make, is that the sickest patients don't always arrive first. In fact, people that, if there's a building collapse, people that can get into a taxi or brought by their family who are lesser injured are the first ones to arrive. The sickest patients don't come until a bit later. So if you tie up all your resources, and it takes a lot of experience and training to be able to make those judgment calls. In the place I am in San Antonio today, if we're operating on a patient who is dying and we think that we cannot further resuscitate them, we bring a second surgeon to the bedside to evaluate the situation, give advice, and it's 2 people making that decision at the same time, which is a pretty smart way of doing things, especially when you've got a lot of junior colleagues who don't have that level of experience.
I'm John Demakis. Thank you very much, Dr. Jenkins. That was a very touching presentation. I was chief resident at Cook County Hospital emergency room for 1 year. I thought I saw a lot of this. Nothing like it. But my question to you, sir, tell us a little bit about, I hear you're a man of faith, active in your church, running the Philoxenia House, which I think is the most wonderful thing I've heard of orthodoxy in this country. How did your faith, your Orthodox faith, help you get through this impossible situation?
It's what got me through. I had a colleague of mine reprimand me when we were getting ready to take a big hospital. We set up the first Air Force theater hospital in over 40 years in Iraq. We went there to take over an Army operation. And of course, the news media was all about capturing the thoughts of the people that were deploying. And as the senior surgeon for the group, they wanted to interview me. And at some point near the end of this interview, the reporter wanted to know if there was one thing that I took with me on deployments that was, just so important as to never be left at home. I said, that's easy. And I reached into my backpack and pulled out my little red prayer book. And that was on the full back page of the San Antonio Express News. And my colleague said, why are you scaring our families? We then proceeded to get mortared and rocketed 400 times in the next 6 months at that location. And you get angry. And when I came home, I had to confess to Father Leo about my anger because I wanted to kill someone. And I'm not saying that in just to the turn of a phrase. I was so angry at being shot at that I wanted to get up in the tower and shoot the machine gun and kill someone who was trying to kill me. Now that's about as far away from a thoughtful theological perspective on medical care as you can get, but it's the truth. And I saw it in all my partners. When they came back, they were angry. And part of them was angry about having been in a deployed environment, but even more so was the bureaucracy at home in the hospital. We never had to fill out a form to get a pint of blood. It just happened. And they were angry about that as well. And so I think I can't say enough about the chaplains, about support of the Orthodox in uniform. Whatever we can do to make that better, it's what gets people through it.
I have a question about this very issue. I'm wondering if you encounter resistance from your colleagues and within the hospital system about chaplaincy and how you think chaplains need to operate in order to make themselves heard and to offer themselves for service?
I haven't heard any resistance. Most of the people that I work with are people of the Christian faith and understand fully the role of the chaplain. I think that they're delighted that the chaplain is there to not only support them but support the patients as well. I actually learned about this when I did my trauma fellowship at the University of Pennsylvania in Philadelphia, where the chaplaincy there was so ingrained in the healthcare team. We had an unfortunate number of young men with fatal brain injuries and a very high organ donor rate. And I put that squarely on the chaplain because it's very hard for a family to walk into an intensive care unit, walk past 3 beds of other young men to get to their boy's bed, and for you to tell them your son is dead. And they can't understand it. Because why aren't the other 3 boys dead? Is it because they're white? And that's an eye-opener to be blatantly accused of racism by someone who, they have no reason to trust you, they don't know you. But the way that we eliminated that was with the chaplains. And the chaplains were very successful at helping people to understand what was going on. So I think being integral to the healthcare team is, if I were in charge, there'd be a chaplain and a prayer at the beginning of every meeting, for crying out loud, because we need that.
I'm a hospice chaplain, and we talk a lot about emotional distance versus emotional connection and stuff with the team. And I was wondering, in terms of emotional distance, that's obviously necessary for the direct patient care in a trauma situation. How do you personally maintain emotional awareness and authentic emotional connection outside of the trauma room and not let the emotional distance become a sustained thing that I would imagine might be part of the contributor to burnout?
Yep. So that resiliency, I'll use that term if that's okay, is what makes one resilient to burnout. Is that you can see the good in the work that you've done. So even though that patient is badly injured, some of the best family conversations I've had have been around the bed of a dying person. And those individuals in that family get as much out of the conversation as if we were having a conversation about how their loved one was going to survive. And I think that's where that comes in for me, is the connection with the family, and then to see patients get better. They struggle through it, but they need every bit of encouragement they can get. I think most of our patients want confident healthcare providers, not confident to a fault. You have to know your limitations. But I do think that, and this is something that is perhaps a little different. I don't know what the other physicians in the room do, but I can tell you that when my son was 10, he had to ask me what I did, because I never talk about what I do at work at home, because home is home, and it's not a place to come and unburden the workplace in that scenario. I get a lot of help, I think, through self-reflection, prayer, and meditation.
Yes, Peter Engel. I'm a VA physician geriatrician in Boston. You spoke about caring both for U.S. soldiers with severe injuries and enemy combatants with severe injuries, and which is really the ethics of medicine, to not be judgmental. But I'm wondering about the emotional, spiritual cost of doing that, and how that might relate to, the term is burnout, but just finding losing one's own sense of value in their work.
So when we took over that hospital in Balad, Iraq from the Army, we inherited about 10 enemy prisoners of war that we cared for on a regular basis with wounds that needed ongoing surgical care. And pretty quickly you get to know those individuals. Most of them were just innocent farm boys who were paid $20 to go set up an IED and then get caught in the act. They were innocent in many regards. That changed when the Marines took Fallujah in the fall of 2004, and we opened a 90-bed prison ward to accommodate all of the injured enemy combatants. Those were professional killers who would look you in the eye and say, when I can get up out of this bed, I'm going to kill you. And that put a terrible emotional strain on the bedside nurses, people with no respect in any way, shape, or form, slapping, grabbing, cursing, spitting. And to work in that environment on a continuous basis, we had to set up an extra rotation. We had to get some extra nurses in from the Navy to spell those people from having to work in that environment repeatedly. And rather famously, I had a sign made. You may have seen signs on the backs of Humvees like "Stay back 100 yards, do not approach this vehicle," and things like that. I had a sign made with the rules of engagement that there's no yelling. There is no, you will not be taken care of if you are yelling. And it's very strict set of rules of engagement for folks that I think made all the difference. And once we got that under control and gained their respect, there were so many of those individuals who identified to us that this is nothing like what we were told. We were told that if we ended up in your hands, you would torture us and kill us. Why are you caring for us? They couldn't get their reality, their mind wrapped around that reality, that there were people who would actually care for them just because they were injured and had nothing to do with why it was that they were there in the first place. So that would be my answer to that.